Hi everyone, this is Arthur Lau from McMaster University in Canada, reporting for Rheumnow.com. This is just reporting on some of the osteoporosis-related sessions from the conference from yesterday. So one of the big things from the conference that came out yesterday was the preliminary ACR guidelines on management of glucocorticoid-induced osteoporosis. It's been a while since we've had a guideline, since 2010, so it's time for an update. So I'll give you guys the highlights of the, and then at the end I'll give you my two cents on it. So they use the grade method for assessing quality of evidence, and it assigns it a letter grade in terms of how good the evidence is. So in terms of the recommendations, they recommend that for all age groups, the patients on glucocorticoid should have clinical fracture risk assessment. So assessing how much glucocorticoid dose they're on, how long you expect them to be on steroids for, risk of falls and frailty, etc. Second thing is that in adults over the age of 40 or more, you should do a baseline 10-year fracture risk assessment using a FRAX, and to do a bone density with the FRAX score as well. One highlight that came from the talk yesterday is that for FRAX, you can actually make an adjustment for glucocorticoid dose. So not everybody is going to be equal. So some patients on very high dose glucocorticoids is not going to have the same FRAX score as those on low dose. I did a Twitter post yesterday with a link to an article that you guys can check out as well on Rheumnow.com. Third thing is to optimize calcium intake, so 1,000 to 1,200 milligrams of elemental calcium per day, and to vitamin D intake, 600 to 800 IUs of vitamin D per day. The fourth recommendation is in men or women at moderate to high risk after you do your FRAX assessment, is to start them on a preventative therapy. The ACR recommends oral bisphosphonates, that's first line, then moving on to IV bisphosphonates like zoledronic acid. Third line will be teriparatide or Forteo. Fourth line will be denosumab, Prolia, and then fifth line in very few patients would be raloxifene, in very rare cases when you're not able to use any of the other four agents. Moving on, the next recommendation is in women with childbearing age at moderate to high risk who should otherwise be on treatment. If they are not planning on getting pregnant during the time they're on steroids, then they should be on a therapy as well, as described in the last on the previous recommendation. For patients with solid organ transplants with renal function with an eGFR greater than 30, they recommend to treat them like all other adults. But they recommended to avoid Prolia, denosumab in that patient population because it may increase the risk of infections with multiple immunosuppressants. And then otherwise in children, age 4 to 17, they recommend to optimize their calcium and vitamin D levels, and only to add a bisphosphonate if they have a fragility fracture in their past history, and they are expected to be on glucocorticoids more than 0.1 milligrams per kilogram for more than 3 months. And then the final recommendation they gave was that in patients at very high glucocorticoid doses, more than 30 milligrams per day, with an expected cumulative dose of more than 5 grams for this treatment course, and over the age of 30, to put them on an oral bisphosphonates first line as well to prevent GOP in that patient population. So overall, those are the new preliminary recommendations. There is going to be some new data coming out in terms of denosumab in treatment of glucocorticoid osteoporosis, which has an ongoing trial and should be coming out. So I suspect some of these guideline recommendations will be obsolete in a few years, but for now, those are our guideline recommendations. There are things that not everyone's going to agree with. For example, I particularly have an interest in renal bone disease, and I deal a lot with the renal transplant population, and I have a lot of experience with using denosumab in that patient population. Based on some of the literature looking at infection rates in RA patients on a biologic plus denosumab, it does not really seem to increase risk of infection. So I suspect people on 5 milligrams of prednisone with some Imuran or tacrolimus with Prolia also should not have a significant increase of infection either. But we'll see in a few years as more data comes out what the right and wrong answer is going forward. Otherwise, this is Arthur Lau reporting for Rheumnow.com. Please enjoy the rest of the conference.